Today, we are very fortunate to have Dr. Shea Duerring. He's an assistant professor in the Division of Pediatric Emergency Medicine. He obtained his MD from Virginia State University. Then he went to do his residency at Eastern Virginia Medical School. In 2016, he joined Children's of Alabama. His research interest is in emergency care service for children. Few months ago, in the beginning of the pandemic, I heard him speak at a seminar that was sponsored by School of Public Health, Deep South Biosafety Worker Training Program, and he was talking about COVID-19 situation in children. And I think it is very timely because we have a lot of schools reopening, daycares, and there's a lot of parents who are worried about the situation in pediatrics. So with that in mind, I would like to welcome Dr. Shea Duerring. Thank you very much for giving this presentation at the EPI seminar. Dr. Duerring, it's your floor now.
Thank you, and thank you for the kind welcome. I'm happy to be here today and to talk about COVID-19 in kids, which unfortunately, as a pediatric emergency medicine physician, has in many ways consumed my life for more than I hoped it would. So, COVID-19 in pediatrics. First off, I have nothing to disclose. I don't have any financial ties to any products I'm going to mention. I'm not being paid by anyone to talk about COVID, so I have nothing to disclose. Basically, we're going to understand some of the epidemiology and spectrum of illness in children with COVID-19, and then we're going to talk about MISC as well. So just to sort of start and give a brief timeline, I know it feels like we've been living in the COVID era for 100 years now. In reality, it actually hasn't been that long, though. In early December of 2019, the first cases of severe pneumonia of an unknown etiology emerged in Wuhan in the Hubei province of China. The disease quickly spread to other parts of China, and within a month, by 3 December 2020, a novel member of an enveloped RNA coronavirus was identified in bronchoalveolar lavage samples from patients in Wuhan who represented some of the first patients in the outbreak. By 7 January 2020, the WHO named it the 2019 novel coronavirus. By 2020, the first US case is reported. So in less than really only barely a month and a half, we've now found the disease, we've recognized it, we've started to sequence it, or the virus started to sequence it, and now it's spread beyond China's borders and even into the US, which is pretty rapid. By 30 January 2020, the WHO declares it a public health emergency of international concern, which is sort of a big deal because that starts to focus the international health community on it. It starts to free up research. And so it's a kind of a big deal step. By 11 February 2020, the WHO names the illness COVID-19 or 2019 novel coronavirus disease. By 11 March 2020, so on my birthday this year, it was recognized as a global pandemic. And by 23 July, when I originally gave this talk the first time, or wrote it for the first iteration, there were 15.3 million confirmed cases with only 600,000 deaths. By contrast, when I looked yesterday at the Johns Hopkins COVID-19 dashboard, just since 23 July, when I first wrote this talk, now to 25 October, we've gone from 15.3 million to 42.9 million cases and have gone from 600,000 deaths to 1.15 million deaths. Of those, the US represents a fairly large majority with the highest number of cases with 8.63 million cases in the United States and 225,215 deaths. And again, that's as of yesterday evening. So children, we know, are obviously slightly different than adults. They're not just small adults. They have different anatomy, different physiology. They also have different immune responses to viruses. In my line of work, things like simple upper respiratory infections and colds, kids tend to get fevers because they just have a more robust immune response to things. And so because of that the COVID-19, like many other viruses and illness, actually behaves very differently in children than it does in adults. And despite the worldwide spread, the epidemiology and clinical patterns of COVID-19 largely remain still at this point even unclear, especially in adults even, but especially in children. As we know, information about COVID-19 changes daily, and so don't take anything I say today as gospel truth, because potentially by tomorrow, I will be completely wrong. But it's an ever-changing landscape that we find ourselves in. This disease behaves and acts like nothing we've really seen before in both adults or pediatrics, affecting everything from clotting to obviously to the lungs, there's neurologic changes. There's been reports of increased incidence of temporal lobe epilepsy in recovering COVID-19 patients. We have reports of myocarditis with inflammation of the heart from COVID-19. And so this disease just behaves like nothing we've ever seen before. And it's an ever-changing landscape as we try and combat the disease and treat these patients. There's relatively few published papers or reports specifically regarding COVID-19 in children, but the data that does exist highlights a few trends that are very important and that raise some very, very interesting questions. And that's sort of what we're going to focus on. One of the first big reports came from Zhang and his group, which was a meta-analysis of laboratory confirmed cases reported in the literature. They looked at 46 articles, many of which were small case reports or case series of 551 confirmed patients. A large majority were from China and Italy. Since at this time, those were really the two epicenters of the disease at this point. All 551 children were hospitalized or treated in the emergency department. Of those, 18% were asymptomatic, 53% presented with fever, 39% had cough, 14% had sore throat or pharyngitis on exam, 7% had sort of nasal symptoms of congestion or runny nose, and then vomiting and diarrhea, so kind of GI symptoms, were present in 2 and 8% respectively, with only 8% really experiencing any sort of respiratory distress. And we know this is obviously very different from the adult population, where a significant majority experience sort of stereotypical symptoms of fever, cough, congestion, and respiratory distress or dyspnea. And so very, very different presentation that we see emerging from this data. Only 9 patients, or 1.6%, were considered severe or critical and required ICU admission. Of those, all but 2 had underlying medical conditions, and only 6 of them required mechanical ventilation. Again, this is in stark contrast to the large number of adults who end up being fairly sick, requiring at the very least oxygen therapy, but a fair portion require, again, ICU admission, mechanical ventilation. Of the patients that they looked at, there was only a single death and a very short median length of hospital stay for pediatric patients, only 12.5 days. This is in contrast to adults, where the average length of stay approaches almost 4 weeks in many patients, especially those requiring ICU admission. So the most common symptom was mild to moderate fever and cough, but again, as we saw from those numbers, much less frequently than reported in adults, and with a fairly high asymptomatic rate. This was a major paper that was published in early March, and this was Dong and his group, which reported on 2,135 patients with COVID-19 from a nationwide case series in China from 16 January to 8 February. One of the weaknesses of this study, while it was a very good study and while it was very well done with excellent statistics, one of the weaknesses and one of the criticisms of this study, though, is that only 728 of those patients were laboratory confirmed. The rest or 1,470 of those patients were labeled COVID-19 based on symptoms and obviously the large community activity that was occurring in Wuhan at the time. And so, again, while many of those probably really were COVID-19 because the community activity was so high, other studies have shown since this that co-infection with other viruses and even other viruses that still present during COVID outbreaks, such as rhinovirus, human metapneumovirus, that we know causes significant respiratory illness in children, RSV also on the list, have occurred. And so there was a little bit of criticism about that, even though most people feel it was, again, probably likely COVID, given how high the community activity was. And one of the big things they did is that they took all those 2,000 plus patients and they broke them down into 5 broad categories based on their disease severity. And so they were either asymptomatic without any clinical symptoms and signs, mild, so symptoms of kind of upper respiratory tract infection, but no oscillatory or respiratory abnormalities and or GI symptoms. So kind of think general cough, cold, congestion. Moderate, meaning they had pneumonia, frequent fever, cough, and some may even have a small amount of wheezing but no hypoxia. Severe, meaning cough with or without oscillatory findings, but with hypoxia, so an oxygen saturation of less than 93%, or critical. And those were children that progressed into acute respiratory distress syndrome, had respiratory failure, shock, myocardial injury. So basically children who were very, very sick and likely requiring ICU admission. They found a median patient age of about 7 years. 4.4% were asymptomatic. And then this was the really kind of red letter thing that came out of this, though, was 94.1% were asymptomatic, mild, or moderate. And so a large proportion of children with either very little illness or only moderate illness requiring mostly just supportive care. Young children, particularly infants, seem more vulnerable, with 10.6% of infants less than 1 year of age being severe or critical. And this sort of mirrors data that we see in other non-COVID-19 coronavirus infections or other viral respiratory infections with kids, again, with things like RSV, human metapneumovirus. We know that children less than a year, and specifically even more so kids under 6 months, tend to be more susceptible to these illnesses, tend to get sicker, tend to require things like ICU admission or step-down unit admissions because they just get sicker from it and are more affected by respiratory illnesses. Overall, only 5.8% severe and critical. So again, very small number. Compare that to 18.5% for adults in the same cohort. So kids, again, seem to get not quite as sick and have less severe disease. 0.6% progress to acute respiratory distress syndrome or multi-organ system dysfunction. And again, out of the 2,000 plus patients, there was only 1 death. They were unable to assess clinical characteristics, so they did not have any data on the symptoms, on the sort of presenting symptoms, whether it was cough, sore throat, GI illness. But it was impressive that they were able to break these down into these sort of categories and really give us a glimpse into what the disease severity is like in children, with, again, a large proportion having asymptomatic, mild, or moderate disease. The one thing is this almost certainly underestimates the true asymptomatic rate, right? Because these are all patients that were seen in the hospital or the emergency department. And so many patients who probably had asymptomatic or mild disease probably stayed home and never presented to care, never went to the hospital. And so we know that while this gives us the notion that a large percentage are asymptomatic or mild to moderate, it's actually probably even a larger number than what the study estimates, since many of those who were not that sick or had no symptoms probably didn't go to the hospital. We talked children without virological confirmation were more likely to have severe disease in this study than children with confirmed COVID-19. And that's an important point, because one of the things, you know, we mentioned a second ago is that there is a high co-infection rate. One study in Sweden showed a fairly high co-infection rate. Another one, 51.35% of children showed COVID-19 co-infection. And with things like RSV and flu, things that are known to make children pretty sick with significant respiratory illness. So you do sort of have to wonder, based on that, with so many, with that high proportion of kids that were non-laboratory confirmed having severe disease, was this pure COVID, or was it COVID with something else? or potentially even not COVID? Was this RSV, which we know in small infants, for instance, can produce significant respiratory illness? And so it does raise a few questions. Another study on COVID-19 in kids was a group led by Pari in Italy. During the height of their outbreak, they looked at 100 Italian children with confirmed no COVID-19 who presented to pediatric emergency departments in Italy. Their median age was about 3.3 years. This was actually published after the Dong study, and they used the same classification as Dong, which is helpful because now we can see changes in an area that's a different outbreak, which could potentially elucidate things like mutating viruses or just different access to healthcare, things like that. And what we see is that, again, a large asymptomatic rate, even larger than in the Dong study, 21% asymptomatic, 58% with mild disease, 19% with moderate disease. And so again, we see the same sort of trend that we saw illustrated in the Dong study. Now, again, with 98% of patients in Italy, of these 100 pediatric patients, with either asymptomatic, mild, or moderate disease. So not getting nearly as sick as adult counterparts tend to. Again, only 1% each in the severe and critical group. There were 0 deaths, 38% required admission, much lower than adults. Symptoms, they were able to collect data on symptoms in this study, which is always helpful because we need to know what to look for in these kids. 54% had fever, 44% had cough, 23% had poor feeding, and these were mostly younger kids, infants, toddlers who are not able to maintain their hydration status and therefore were coming to the emergency department. 10% with nausea or vomiting, 9% with diarrhea, and 4% with sore throat. So again, we see that in kids, only 54% with fever, which is in stark contrast to adults, 44% with cough, again in contrast, where stereotypically adults almost universally get fever, cough, and some sort of respiratory symptoms. Again, so kids tend to have much different symptoms than adults, even from asymptomatic to maybe a mild cough but no fever. And so in the US, there's only been a couple published studies looking at kids in the US. In the US, the CDC actually published a report of coronaviruses in 2019. On 6 April, they published one of their MWWRs, and which were significant, but there were significant data gaps and very limited clinical details based on the reporting and how they collected the data. And it really wasn't that useful, to be very honest. It gave us very little insight on what COVID-19 was looking like here in the United States at that time. There's been 2 other published reports. One group reported on 65 patients with confirmed COVID-19 at the Stephen Alexander Cohen Children's Medical Center in New York. Median age of 10.3 years. So we've seen everything from 3 years to 7 years to 10 years as median age now. Infants under 60 accounted for 29% of their admissions. Children over the age of 12 were 48%. 69% presented with fever, 49% with had cough, 40% had poor feeding, 35% had shortness of breath, 28% with nausea, vomiting, 11% with diarrhea. 3 had no symptoms and were there for completely other reasons. And so again, you're seeing a fair number of kids who are presenting for asymptomatic illness or with GI illness. It does seem that kids have more GI illness compared to adult counterparts with the nausea and vomiting, diarrhea. And again, we're seeing the same trends of not universally having fever, cough, but poor feeding being a big one in this study, as well as the previous one we had talked about. Healthy children, immunocompromised children, and chronically ill children present with lower respiratory signs more frequently than healthy infants. 34% in this study required respiratory support. They did break these down into classifications similar to the Dong study, although they did not break it into severe and critical. They just sort of group those together. But 60% had mild illness, 26% had moderate illness, and 14% with severe illness. So, and a great proportion of those with chronic medical conditions developed severe disease. And so we see sort of similar trends in that a large percentage of kids, 76% in this study, had mild or moderate illness, with some asymptomatic illness as well, like we mentioned in the previous slide. And again, kids with chronic medical conditions tend to get sicker. Another group reported on 22 patients with confirmed COVID-19 admitted to their hospital in Brooklyn, New York from 18 March to 15 April. One of the interesting things about this study is that initially when they started this study was when their hospital was doing only targeted testing based on the initial CDC recommendations, which originally said you had to have fever and respiratory symptoms to get tested. And so what happened is about 2/3 of the way through their study, the hospital started doing universal screening because we realized those original recommendations maybe didn't necessarily actually represent the kind of illness we see in kids. And so what happens, and we'll look at the numbers in a second, is as they started universal screening, they started finding kids who were there for completely other reasons and asymptomatic from COVID, but had COVID. For instance, one kid was there actually for abdominal pain and had appendicitis, presented for an appendectomy, and was found to be COVID positive on their OR screening test. And so the interesting thing is that it gives you sort of a look at the illness that we can see in kids, and that they can be largely asymptomatic, looking at these kids who weren't even there for COVID-19. So infants under 1 year of age, again, accounted for 45% of hospitalization. So we're again seeing that trend that younger kids, 1 year and less, tend to get a little sicker. The most common presentation was fever without any other source, and otherwise healthy infants prompting a workup. So young kids who had fever and would get a workup anyway, because we work up, all babies 2 months of age and under get workups for fever because they're considered immunocompromised essentially because of their not developed immune system. And that was 23% of them. Only 41% or 9 patients actually presented with respiratory illness. 32% required respiratory support, and 18% or only 4 patients really required mechanical ventilation. 2 of these had underlying pulmonary disease. One of them had plastic bronchitis, and I can't remember. I think the other one had just chronic asthma. One presented to the ED in cardiac arrest and had return of spontaneous circulation after working the arrest. There were 0 deaths in this study. Even the patient who was in arrest actually lived. So and here's the interesting part that we touched on a little while ago. After implementation of universal screening, they identified 9 or 41% of patients who would have been missed with the original targeted screening criteria of the CDC requiring fever and some sort of respiratory symptoms. Most recently, this is the most recent study we have on kids, and looks at a large review article published by Hone et al. In the eClinical Medicine journal, which is actually run by the Lancet, and looked at COVID-19 in children. They did a large database search and identified 1,142 articles. After they removed duplicates and excluded some studies based on their criteria, some of them were editorials, some of them were non-peer reviewed, and some of them didn't look specifically at kids. They excluded a few studies because they looked at neonates who looking at transmission from COVID positive mothers. Once they looked at studies that really met their criteria of looking at pediatric disease of COVID-19, they were left with 131 studies, which looked at 7,780 COVID positive children. This did include the Dong study and some of the ones we've already mentioned. And some interesting things start to emerge. 56% male, which is what you would expect. Median age of 8.9 years. 33% of those patients were from the United States, which is the largest proportion we've seen in any study so far. 26%, there were 26, total countries which were actually represented in this study. So get a large cohort from the United States, but also looking at disease in other places. The next most common were China and Italy, which would sort of be expected based on where significant disease has been reported on. 3.3% required ICU admission. So again, we're seeing a very small percentage of patients who require ICU level care in children. 35.6% had underlying medical conditions, mostly immunosuppression or some sort of cardiopulmonary disease, underlying respiratory illness. 72% had a co-infection rate. And this, sort of touches back to some of the limitations we talked about with the Dong study. The previous study I mentioned from Sweden talked about a 50% co-infection rate, but here we're seeing as high as 72% co-infection rate. Again, these looked at mainly admitted patients or patients presenting to emergency departments, so patients who were presenting to care. And so again, you think that these would likely be sort of just by their nature sicker patients because they're actually presenting to care. They're not just staying home and taking care of their cough and runny nose. And so it does, with that high percentage of co-infection rate, does make you wonder about the patients who are more ill and wondering about co-infection with things, in this case, mycoplasma pneumonia and influenza were the most common co-infection. And so it does sort of make you wonder about testing, expanding testing, looking for not just COVID, but other viral respiratory pathogens in some of these sicker patients. Or previously, when we actually started screening these kids based on CDC recommendations, we would do flu, rapid flu and viral respiratory panels. And if those were positive, we actually wouldn't test those patients for COVID. And so now maybe we should have been testing more of those. In hindsight, we know maybe we should have been testing more of those patients for COVID, given that a lot of these sicker patients who are presenting to care, do seem to have a very high co-infection rate with other illnesses that are known to make kids sick. So 119 studies that they looked at classified clinical symptoms. 456 out of 2,367 patients or 19.3% were asymptomatic. The rest of them all looked at 2,445 patients. And you can see the proportions there, but 59% with fever, 55.9% with cough, 20.5% with rhinorrhea and congestion, 18.7% with myalgia and fatigue, 11.7% with dyspnea and shortness of breath. Again, we see a percentage of kids larger than in adults that tend to present with GI symptoms though, abdominal pain, diarrhea, vomiting, nausea. And again, we see the 1.7% or a fair number who present because of decreased oral intake and clinical dehydration requiring care. But again, this mirrors trends that we saw in the other studies that we've talked about with about half of patients with fever, a little over half, but previously we saw under, so right around half with cough, about a quarter with sort of nasal symptoms. But again, we see that large percentage of asymptomatic patients, 19.3%, which is close to the 20% we saw earlier, and sort of mirrors a couple of the other studies, which is much larger than the Dong study that reported that presented around 4%. But again, it was one of the criticisms of the Dong study that again, it probably underrepresented those patients. All studies did include outcome data, and 0.09% or only 7 fatalities of all those patients that were reported on. 0.54% or 42 required mechanical ventilation. 0.2% or 19 had signs and symptoms of shock. And this was the first study that looked at COVID positive kids who met criteria for MISC, which is this emerging kind of illness that we'll talk about in a second. And interestingly, only 0.14% or 11 met diagnostic criteria for MISC. And so we're seeing similar trends of kids tend to do better. Their prognosis is good. Only a small portion require ICU level care for shock or requiring mechanical ventilation. And mortality still remains quite low in kids, even looking at all these studies now with a larger kind of group of time and in multiple countries. we know that mortality in kids still tends to remain very, very low. So what does all that mean that we've talked about? COVID-19 in kids is variable, and it presents as a spectrum of illness. And this is what makes working with kids with COVID-19 very, very difficult, because a large percentage of asymptomatic. At Children's of Alabama, when we started universal screening for children, when we were admitting kids with symptoms of COVID-19, fever, cough, congestion, we actually, in 1 week, out of the 75 to 80 kids that we admitted with those symptoms, we only had a positive rate on our COVID screens of about 4 to 5%. In that same week, our trauma team, since everybody got admitted, worked 4 gunshot wounds to kids that went to the ER, 3 of which were positive, so 75%. Now, again, obviously that percentage is a little skewed based on numbers, but it does sort of drive home this point that we really do see a spectrum of illness in kids, and that from asymptomatic, we know that kids get a larger percentage than adults have GI symptoms. We looked at those numbers with kids with nausea, vomiting, diarrhea, and then even presenting to cold and sort of bronchiolitis type syndrome. So kids who present with cough, congestion, fever, kind of mild to moderate symptoms. And then kids who present with acute respiratory failure and even in shock. So that it's sort of a continuum, if you will, of kids who go all the way from asymptomatic to being very sick, with, again, a large proportion falling in that asymptomatic, mild and moderate disease. But it does make sort of finding and diagnosing COVID in children a little more difficult. They don't have this sort of stereotypical presentation of adult that you can look at and go, well, that's probably COVID. Only half or less of patients, in fact, will have that standard presentation with cough, respiratory symptoms, and fever. Looking at numbers, we saw about 50%, right around 50% plus or minus in every one of these studies with fever and cough, congestion, and things like that. Most kids do quite well, like we talked about, and generally only require supportive care. Right now at Children's of Alabama, we have universal screening for admissions, but we are not testing patients who are not critically ill or being admitted in our ER. And the reason for that is that at this point, it honestly doesn't necessarily change our treatment for those patients. We're referring them to outpatient testing centers to get their testing as a way to conserve testing materials within the hospital, but also because it doesn't necessarily change our treatment. Again, most of these kids do quite well with supportive care, just like we would treat them for a standard upper respiratory infection or bronchiolitis type illness. Young infants and children with chronic medical conditions seem particularly vulnerable to COVID-19, and that honestly just mirrors trends that we see with other respiratory illnesses. Fever alone and decreased oral intake seems to be the most common presentation to medical care in kids. So fever and decreased PO intake. And this is what makes it, again, very hard in kids, because on any given day, I will tell you that represents about 50 to 60% of patients that present to Children's of Alabama for care to our emergency department, even before COVID started. And so fever and decrease, every kid who gets sick, who gets a fever, whether it's from a URI, from bronchiolitis, from flu, from anything, all those kids don't tend to not eat and drink as well. They tend to get somewhat dehydrated. And so this is what makes our jobs in the pediatric world very, very difficult, because this is 60 to 70% of our ER some days, especially in the winter when flu and bronchiolitis season hits. This is sometimes 80% of our ER on a given day. So trying to sort out who may potentially have COVID versus who has, rhinovirus or human metapneumovirus or non-COVID-19 coronavirus, which is actually the second most common cause of bronchiolitis behind RSV in kids, starts to become very difficult. We can't sort of rely on that standard fever, cough, and respiratory distress triad to screen these patients that adult providers can. And so what does that mean for PPE? Well, we talk a lot about PPE and having safety equipment available. We burn through a lot because we don't have the typical presentation that allows us to say, okay, I don't need everything for this patient, but I do for this. We typically need it for more patients because it's harder for us to tease out who may or may not have it. Also, the one thing about kids is they tend to cry, especially infants. Infants is actually aerosol, or crying actually is aerosolizing. And so when these infants are crying while we're examining them or trying to do nasal suctioning on them, those are all things that actually aerosolize. And so we use our N95s a lot. And typically our recommendation for kids when seeing kids is that a minimum of N95 eye protection for all pediatric patients with other PPE based on their presentation and potential exposures. And so let's talk about MISC now, because this has been something that's getting a lot of press and media. It stands for multi-system inflammatory syndrome in children, and it's related to COVID-19. It is initially identified in the UK and has now been seen in the US. The CDC definition is in any individual under 21 years of age with fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization with multi-system organ involvement, and no alternative plausible diagnosis. So you can't have your, shock related to a injury, and positive for current or recent SARS-CoV-2 infection. Symptoms include persistent fever, inflammation, and evidence of end organ dysfunction and shock. Frequently, when we're talking about end organ dysfunction, the three that we see the most commonly are the heart with myocarditis and cardiogenic shock, kidney injury, so acute kidney injury with elevated creatinine, and liver damage or liver injury with mild hepatitis with elevation of the patient's liver function testing. Signs of MISC overlap with Kawasaki's disease or toxic shock syndrome. Kawasaki's disease we frequently see in kids, and with cracked red lips, conjunctival injection, rash, strawberry tongue, extremity changes, and by that we normally mean like peeling skin over the palms and feet and so over the extremities. You can get some swelling in the extremities, and coronary artery enlargement or aneurysms. Interestingly, this is not the first time that Kawasaki-like illness has been linked with a coronavirus. During the New Haven coronavirus outbreak in the about 15 years or so ago, we saw a similar report of Kawasaki's type illness with coronavirus, with that coronavirus outbreak. And so when we've never really elucidated the cause of Kawasaki disease, it's been postulated for years to be a viral trigger. And so it's interesting now that we're seeing a second novel coronavirus with this sort of Kawasaki's-like presentation with significant inflammation. Commonly reported symptoms with MISC also include abdominal pain, diarrhea. So again, we're seeing the GI symptoms, headaches and encephalopathy, abnormal clotting, myocarditis, poor heart function, and acute kidney injury have also been reported, like we talked about. And most seem to develop symptoms 2 to 4 weeks after COVID-19 infection. So, laboratory abnormalities include elevated inflammatory markers, so a CRP, ESR, ferritin, lactate dehydrogenase level, abnormalities in their blood counts, and normally we're talking about lymphopenia with thrombocytopenia and neutrophilia, elevated BNP or B-type natriuretic peptide, which is a elevated marker of cardiac stress, frequently seen elevated in patients with heart failure, and D-dimers. So who to suspect? Well, this is the hard part of this for us, because really persistent fever without a clear clinical source. And the CDC has actually recommended looking for MIC in patients who have 3 days of fever, and then fever accompanied by any of the above symptoms with a recent history of COVID-19. And again, this is where things get a little tricky for us in the pediatric emergency department, because many of our patients present with fever and a lot with fever, with persistent fever, 3, 4, 5 days of fever. They've been sick at home. Family's been caring for them at home. They're now on day 3 or 4 of illness. Family starts to get concerned, brings them to the emergency department for evaluation. And again, that key phrase there is with a known history of recent COVID-19. And that's great, except that we've talked about a huge proportion of kids have either asymptomatic or mild disease. And so this presents a difficulty for us, because normally that would be something that we would use and say to screen out patients. And we'd say, oh, you've had 3 days of fever, but you haven't had COVID recently. However, in our patients, if they've had even a cold in the last 4 weeks, then they could potentially have had COVID-19. Since again, a large proportion of patients present with sort of cough, fever, and sort of mild illness. And the problem is, find for instance, toddler, 2 or 3 year old who's in daycare who hasn't had a snotty nose or a cough in the last, 3 to 4 weeks. And so we have been looking for the number of patients that we've been looking at we've been getting labs on, who are looking for this information, who are doing MISC workups on, has been astounding to me. I mean, I did this 3 times in one shift recently, because again, almost all my patients are there with fever, congestion, decreased oral intake, and have had some sort of mild or moderate illness in the last 4 weeks. And so we're working up a lot of kids looking for MISC, because it's so hard to sort of screen anybody out with this criteria. And the problem is that if we miss it, these kids tend to progress very rapidly. They tend to get very sick. They develop shock-like symptoms. They can develop coronary artery aneurysms. They can go into renal failure. And so missing MISC is not something we want to do. Again, currently the CDC recommendation is evaluation of children with persistent fever greater than or equal to 3 days. And again, that sort of is a complex issue for us, because even looking at simple upper respiratory infections, which tend to give kids fever, things like rhinovirus, non-COVID coronavirus, typically kids get symptoms for around 7 to 10 days, with fever lasting for 3 to 5 on average. And so even your average kid who has an upper respiratory infection is going to screen in based on these criteria. And so it's been very, very difficult for us to sort through these kids and try and figure out who we need to test, because it's a lot of blood work and it pretty much buys you an admission to the hospital. And so it's very, very difficult for us, trying to be careful. We don't want to over screen, but we also don't want to miss somebody who could potentially rapidly get very, very sick. Treatment for MISC has been very similar to that of what we treat Kawasaki's disease with IVIG. And if they do have that sort of stereotypical Kawasaki's type picture with the overlap, those patients get aspirin therapy as well. When I first wrote this talk in July, at that point, there'd only been 300 cases in the US with 4 deaths. Now, as of yesterday, the CDC's most recent numbers are up to 1,097 cases with 20 deaths. We've had several cases at Children's of Alabama. It is happening in Alabama. And we're starting to find more as we're looking more, again, with this criteria being sort of difficult for us to use to sort. It's a very sensitive criteria, but not a very specific criteria. And so while it makes a good screening test, it does mean that we're looking in a lot of patients that we wouldn't normally otherwise sort of look in. We're learning every day about this illness. And how does this affect school decisions, knowing that a large percentage of these kids will be asymptomatic and not necessarily present with significant illness, may even be afebrile, if schools are checking temperatures. Does that make us feel significantly better? And one of the things that we really don't know is how efficient are children at spreading COVID-19. And so if these kids are getting ill, if they are asymptomatic, what does that mean for their viral load? Are they still effective spreaders of COVID-19? Because right now we've actually been very lucky, and despite schools going back in person, we haven't, now colleges aside, elementary schools, young kids, we have not had any major significant outbreaks thus far. And so there's a lot of unanswered questions from a public health standpoint that really all these studies sort of bring up with how do we screen people for COVID and test? Who do we test and not test? Who do we look for with MISC? How effectively is it spread, and how does that affect our decisions of kids going back to school in person? And then who are we protecting? Are we protecting kids? Are we protecting the elderly, multi-generational a lot of multi-generational families, especially here in the Birmingham area, where there's elderly patients with comorbidities in the house? So it's really now at this point, a lot of interesting public health questions that sort of arise from this that have yet to be answered, unfortunately. Here's a list of citations and studies for anyone who are interested.